morning. I'll try to cover 3 articles on functional seizures today, and we'll be recording this talk. So the first article is basically in the CHUM in Montreal in Canada. It's done by Rachel Abinahed and the team, and basically it's about the outcome of psychogenic non-epileptic seizures following diagnosis in the EMU. And this is from February 2024. So we'll start just like by a brief introduction. Most of you are familiar with that, but in 2011 and 13, the International League Against Epilepsy and the Non-Epileptic Seizure Task Force recommended basic management, which are diagnosis by video EEG, which is the gold standard we do, adequate communication of the diagnosis to the patient and the relatives, and the gradual withdrawal of anti-seizure medication in patients with a diagnosis of PNES without concomitant epilepsy, obviously, and prescription of psychotropic drugs or for comorbid psychopathologies and long-term follow-up. Now, basically, the long-term prognosis is unclear. Many studies tried to cover that, and some found that beyond 1 year after diagnosis, less than 40% of patients had complete control of their functional seizures. And about 63% in other studies reported having had complete control during the last 3 months when assessed. So we don't know what's the long-term prognosis. And 76.1% of patients reported that at least their last episode was more than a month ago, meaning a month prior to the time they were interviewed. Now, most of these studies do not really differentiate between patients with PNES only and patients who have concomitant epilepsy. And there is one study by Sedan et al. And suggested that the cessation of long-term functional seizure in patients with concurrent epilepsy may be more likely than in patients with psychogenic non-epileptic seizures alone. And other studies suggested otherwise. Now, basically, it's difficult to compare these two groups, like functional seizure only versus functional seizure and concomitant epilepsy, because there is a significant proportion of patients and their caregivers cannot really discriminate between psychogenic seizures and epileptic seizure when they have both at 1 year of follow-up. And also the control of functional seizures, although it's important and the main measure of the outcome in the studies, it's not really representative measure of medical and psychosocial outcomes. Now, going back to the study, what are the objectives of this study? It's basically to study the outcome of patients with functional seizures after their diagnosis in the EMU. Now, again, this study was done in L'Oreal, and basically they looked into patients who were diagnosed with functional seizures between January 2009 and May 2023. And the definite diagnosis was made by history and video EEG together. And basically, patients with probable PNES or other like functional neurological disorders were excluded. And patients exhibiting both epileptic and seizures and functional seizures were excluded in this study due to the factors that I mentioned before. Now, they did phone, the way they did the data collection, they did phone interview. They looked into the demographics, gender, age. They looked also like on information relating to the functional seizure semiology, comorbidities, frequencies, and prescribed medications. They also looked at the outcome data, which is the frequency of the functional seizures, number of the visits to the emergency department, general practitioners, like number of visits, whether to ED or like to practitioners, neurologists outside of the scheduled follow-up, and the use of antidepressants or anti-seizure medication. And also they assessed the ability to work and go back to work if they were on leave. Now, this data was compared to information written in the medical record when available in case of discrepancies. And they also the answers provided by patients during the phone interviews were retained if there was any discrepancy. Now, they looked into the number, they compared the number of participants with daily functional seizures, the number of visits to the emergency room, general practitioners or neurologists, and also participants who took antidepressants, antipsychotics, or anti-seizure medication, and also the patients who had psychotherapy sessions. And they were compared to pre and post AMU diagnosis. Now, initially, they identified 360 patients, but they excluded the overwhelming majority, about 257 patients. They included 103 patients, but of the patients of these that really kind of fit the inclusion criteria, only 29 did not were unable to reach them, and 13 declined to participate. So they were left with 61 patients with a response rate of about 59.2%. Now, like with the results, so before the PNES diagnosis, obviously the demographics wouldn't change in general, but basically a female gender was about 79% of the cases. Now, they found that the age of onset of functional seizure was had a median of 35 with a range of 18 to 44. And basically employment, they look at employment, and they found that about 25% were employed and working, 46% were on temporary leave from work, while 23% were students. The rest were unemployed or retired. Now, for the highest level of education, university was 25%, and high school was 26%. Now, they found that, as expected, that a majority of the patients, 69%, had psychiatric disorders, including, on top of the list here, anxiety, followed by depression and personality disorders. And other functional symptoms were present, and basically there were pain and headaches. And only 34% had history of sexual abuse based on this study, while 7% only also had a history of or reported physical abuse. Now, they looked into the main clinical manifestations of the functional seizures, and 59% of patients had obviously more than one clinical feature, but if they stratified them, 36 patients had motor symptoms, 23 had behavioral arrest or contact break, and the third on the list was sensory symptom, in addition to language symptom, lightheadedness, headaches, visual or auditory hallucinations. Now, before the diagnosis, as we see here, that about 38% of patients had daily functional seizures, and about 66% they consulted their general practitioner for functional seizures outside of the scheduled regular follow-up, so kind of more of an urgent follow-up. And 90% they saw the neurologist for the same reason. About 51% were already on antipsychotics and depressants, and 70% were on anti-seizure medication. Now, they also looked into like other characteristics. They looked into the delay in diagnosis, and they found that basically the median was about 3 years delay with a range of 1 to 7 years. And the time spent in the EMU to have a diagnosis was up to 5 days, with a range with up to 8 days of EMU days spent. And they had about 3 seizures each recorded in the EMU. And the overwhelming majority had the diagnosis, which is expected, given or announced in the EMU, and only 48% were discharged to a functional neurological disorder program. Now, seizure freedom after the diagnosis. So after diagnosis, they assessed the functional seizure freedom, and it was obviously defined as complete absence of events at the time of follow-up. And basically, 46% had achieved complete freedom, and of these, 32% stopped immediately upon communication of the diagnosis. And this kind of reminds us of all the studies that were done about the kind of the healing process starts with the communication of the functional seizure diagnosis. Now, the median time required to achieve the freedom after diagnosis was about 3.5 months for patients who did not immediately stop. And many patients, up to 38%, had a reduction in the daily seizure frequency. And the median follow-up duration for these patients was about 51 months, and 93% of participants had a follow-up of 1 year or more. Now, what are the list of factors that led to the freedom from functional seizure? And this is basically more self-reported by patients and asked by the interviewer on the phone. So many patients mentioned that 18% had lifestyle modification to prioritize mental health, 21% had psychotherapy and better stress management. And while understanding the diagnosis in 20%, some patients did not know why, and it was significant, like 21%. And other had different reasons like anti-seizure medication, antidepressant, psychiatric care, etc. Now, of the patients who continued to have seizures after the diagnosis, 33, these were 33. And but all these patients reported some kind of type of improvement. So 52% had less intense seizures, and 73% had a reduction in the frequency, and 39% had shorter or briefer seizure duration. Now, after the diagnosis, and as we see here, the numbers dropped. Maybe I should go to the, let's see. So basically, after diagnosis, you can see here, I went back, but I think that's a better slide. And basically, you see that there was a drop from in the urgent follow-up visits with the general practitioner or the neurologist. So it dropped for the neurologist from 90% to 33%, and the same for the general practitioner from 66 to 28%. And obviously, only 33% continued to take anti-seizure medication, which was based on in the discussion that it was kept for non-epilepsy reasons. Like, so sometimes they were on topiramate or other medication that were used for other reasons, not for the seizures. And also patients, there was an increase in employment and working from 25% to 49%. Now, we did speak about that. Now, let's move to the discussion about this article. So in this cohort, about half of the patients had complete remission, and only 18 reported daily functional seizures after the diagnosis. Prior to that, it was 38%. So there was still reduction even if patients continued to have seizures. And these are on the higher end of remission rates compared to prior studies. Prior studies were like in the 40s, mid 40s percent, maybe low 50s. And there was a significant reduction in anti-seizure medication use, which kind of is expected. And the numbers are in line with previously published rates of approximately, sorry, 2/3 of patients receiving anti-seizure medications prior to the functional seizure diagnosis, and the persistence of around 25 to 40%. Now, there's also a decrease in the emergency department, general practitioner, and neurologist follow-up visits after the diagnosis. And there's an increase in the employment rate from 49% from 25% to 49%. And also there was a high rate of acceptance. About 89% of patients accepted the diagnosis, which contributed to some degree to the improvement. And most patients had 97% had their diagnosis discussed in the EMU before discharge. Now, the limitations are the modest size, sample size, the generalizability due to recruitment issues, because they only studied patients who agreed to participate, and we don't know about patients who did not agree to participate and or did not respond. They could maybe have worse prognosis. So that actually may overestimate the improvement in outcome. Now, this study is retrospective and it was done in a tertiary center. So basically, it is not representative of population with functional seizures in community centers or non-academic centers. I can pause a bit here if somebody has any questions or comments. I see a chat question. Dr. San Juan, any of these patients were referred to psychiatric consultation to management in outpatient clinic? Yes, so but they don't really say the details, but yes, let me see. And we know that these patients had, well, so they were referred to psychotherapy, but they did not really specify and psychiatric care. But we don't know. I don't have the numbers. How many like percent of all these? How many were referred to psychiatric centers and care? All right. Let me see if we are missing something in the chat. So basically, today it's like an overwhelming topic on functional seizures. So all three articles. So basically now another study about young people and who were diagnosed with psychogenic seizures and how are they doing years later. So this was done in Oslo by Cartrud and Henning and et al. And this was also published in like earlier this year in Epilepsy and Behavior. So in a population-based study of the prevalence of functional seizure is it's kind of more difficult to assess compared to epileptic seizures or other like neurological conditions. But so based on a study in Norway, they found that functional seizure in Norway was about 23.8 per 100,000 persons, and in other studies, the highest prevalence between in the age group 15 and 19 to 19 years was up to 59.5 per 100,000. So about 30%, and in that center, about 30% of patients that were referred for epilepsy, for drug-resistant epilepsy, turned out to have functional seizures, which is pretty comparable to other studies. Now, also the thought is that possibly young people with functional seizures may report a lower or poorer quality of life and compared to the general population, and even may drop out of school or working life. So based on that, this study basically examined young people with functional seizures at the age of 2 and 9 years after, not the age, sorry, within 2 to 9 years after discharge from a multidisciplinary national hospital in Norway for epilepsy. Basically, the aim was to determine the long-term seizure prognosis and basically freedom from the seizures, improvement or lack of change or even worsening, and also to evaluate possible relationships between seizure outcomes, demographic, treatment received, current satisfaction with health, and participation in education or work. So patients between the age of 14 and 24 years old, upon the admission, they stayed there, it seems, for up to 4 weeks. And patients stay between January 2012 and 2020 were followed. and studied. So basically, they during the hospital stay, they all attended psychoeducation course to educate them about psychogenic non-epileptic seizures in general and coping with seizures and possible contributors to seizure susceptibility. Now, they excluded patients with intellectual disability and patients with also epilepsy, comparing to the prior study. Now, they identified 258 patients, and they were contacted by, these patients were contacted by messages, and like they kind of gave them some information and consents, and they patients who kind of agreed, they were contacted by phone and interviewed. So only 62 patients accepted, and out of these 10 were excluded, I believe, because they found that they have epilepsy or like missing data, but basically only 52 patients were retained in this study. The mean age was 20.9 years with a range of 16 to 28, and there was a predominance of women in the study. So 87% of the cases identified were women. Now, the mean follow-up time was about 4.7 years after the discharge or the diagnosis. Now, let's move to the results. And basically, after a mean of follow-up of 4.7 years, they found that about 53.8% were seizure-free. And the specific question was like 6 months from the time they were interviewed, how many seizures did they have? And technically 53.8% were seizure-free. 30.8% had improved seizure frequency, and while 5.8% were unchanged and 9.6% were basically worse. Now, they looked into the different therapies received, and like the majority had conversational therapy, simply speaking about the diagnosis and trauma, for example. And 73% treated with psychologists or psychiatrists. 40% were treated by general practitioner. 19% were followed by neurologists, and 42% were treated by school nurse or psychiatric nurse at that time. And 15% had family therapy, and 61% were treated by psychomotor physiotherapist. Now, only 40% were satisfied. So they asked the patient about their satisfaction with in regard to the therapy. So only 40% were satisfied. 44% were neither satisfied or unsatisfied, and 14% were unsatisfied with the treatment they had received. Now, again, 69% of the patients were under the age of 18 at the time of the hospital stay. We mentioned that female gender was the most prominent, 87%. And patients at the time of the study, 56% were in high school. 94% said that they have like the seizures made the completion of school and education more difficult. 21% only had full-time work. 44% had part-time work, and 54% have they reported that the seizures made their work life more difficult. We spoke about the treatment. Now, for the perception of the own health and quality of life, basically 65% of the patient perceived their own health as being good. 17% said that it was bad, and only 15% said it was very good. Now, young age and satisfaction with treatment also, like the authors found, but this was not statistically significant, that young age and satisfaction with treatment were independent predictors for working and receiving education. And satisfaction with treatment was also a predictor of being satisfied with one perceived health, but also that was not statistically significant. Now, the main findings in this study is that basically 54% of patients were seizure-free after a follow-up of 4.7 years, about 5 years. And this is a higher rate than most of the studies. And this is a longer time frame compared to the prior one. But it's also, again, like it's very, like it mirrors the prior study in the the limitations, in the sense that it could be still a selection bias because they only interviewed patients who accepted. So many refused to be in the study or did not reply. So maybe they had a worse prognosis. So that will kind of gives an overestimate of the prognosis. And there's a possible explanation that this cohort was also the patients were young. So young patients tend to have a more favorable outcome compared to patients who are older. And also, the authors found that a young age and satisfaction with treatment increased the likelihood of working or receiving education by almost 6 and 4 times. But remember, it was not statistically significant. Now, that's the point that we all kind of encounter. So classically, basically, like we do, the authors had the same observation. They basically diagnosis made by neurology and the treatment by psychiatry. And patients tend to fall in the gap between these two disciplines. So like how many times you see a patient in the unit, you diagnose with functional seizures, and then you give them referrals for psychiatry, but then they don't see psychiatry in any case. So they fall in between these two disciplines. And even with early referrals, some like had the referral to like psychotherapy or psychiatry refused. And a 3/4 of the patients were still seen and had conversation therapy, which was found to be helpful. So like if you remember from the prior slide, that 73% of the patients, or more actually, 75% had conversation therapy. And that was possibly helpful in the seizure reductions for those who benefited. Now, another point is that about 19% dropped out of school, which is a concerning risk factor for social isolation. And the reasons for dropping can be multifactorial. You could have basically many would be like told that they're faking the seizures. They might have bullying at school and exclusion. And also, like they would have learning difficulties, which will, and an increased occurrence of risk of psychiatric disorders, which all can lead to dropping out of school and work, which will also lead to worse outcomes. Now, again, some limitations. They had a low response rate, about 24%. They did not have any knowledge of the, like mentioned in the prior slide, about the 196 non-responders, which brings up a selection bias. And it's unclear if the results are representative of the lessons in general overall. All right, so I'm trying to cover all three, but I don't want to be running pretty fast. So if anybody has any questions, please don't hesitate.
I have a quick comment, Yaman. You might know this. I'm always on the fence about using the word seizure in these kids. I don't know if you know, is it beneficial to use that word or to move towards using episode or spells with them? I don't know. It just gets confusing, I think, sometimes.
Definitely. I mean, this is kind of a discussion now. Like sometimes spell also sounds a bit not confusing, but sometimes some might consider it as less of a clinical diagnosis. If I'm expressing myself well, basically it's like it's a spell. It might have some connotations compared to like episode, for example. I personally tend to say episode or seizures sometimes, and functional seizures. Now I'm using basically the term functional seizure, and I'm kind of stressing we have like non-epileptic seizures, and we have we have epileptic seizures and we have non-epileptic functional seizures. So because sometimes they might not basically like they won't really appreciate or like won't be really understanding of the word spell because of the other connotations to that word. Yeah, we use non-epileptic events. So I use event pretty frequently or yeah. Okay, so I'm going to move to the third and last article. So psychogenic non-epileptic seizures in individual with intellectual disability and borderline cognitive function. So I'm going to go over this study also. And this is from also earlier this year in 2024, and it was done in Milan by Ricci et al. So individuals with intellectual disabilities are a significant yet overlooked subset of patients with PNES. And on average, 9.4% of patients with individuals with PNES have intellectual disabilities. And so basically in this study, they focused on borderline intellectual functioning and intellectual disability. So basically, for intellectual disability, the diagnosis is basically based on the functional, on the individual having an IQ of 69 or less, and obviously showing impairment in social and adaptive malfunctioning since childhood. While for borderline intellectual functioning, it's an IQ that ranges from 70 to 84. Now, in view of the scarce studies, the authors evaluated patients with functional seizures and aimed to describe the differences between those and with or without ID and borderline intellectual functioning. Sorry about the sound. Yeah. So what are the methods? So basically, in a center and hospital in Milan, they looked between the San Paolo hospital in Milan. They looked into like between 2008 and 2021. They selected patients above the age of 14 with documented diagnosis of function or PNES or psychogenic non-epileptic events, and they basically found like they looked into the presence of neuropsychological evaluations, obviously for the IQ levels. And also they looked at the medical chart that contains sufficient information to support like both diagnoses. Now they reviewed when they selected these charts, they reviewed the medical records and they looked into demographics, clinical and neuropsychological data with possible prognostic value, and also they reviewed the video EEG recordings to describe the seizures themselves or the functional or the non-epileptic events. Now they also when they selected the patients with non-epileptic events or seizures, basically they divided them into two groups. They basically had a group with non-epileptic seizures and with normal IQ, and patients who had functional seizures with intellectual disabilities or BIF. Now they also characterized the type of seizures they had. Now, in comparison, so basically they compare the demographics, the clinical and the prognostic data between individuals with and without mild intellectual disability and BIF. So basically, they had 25 patients in each group, and they had about 12% in each group had physical or sexual abuse before the onset, and 60% in the normal IQ group had a stressful event at onset, while 52% in the intellectual disability group. And the anxiety or depression prevalence was also the same, about the same, 44% in the normal IQ and 48% in the mild intellectual disability. And personality disorder was more prevalent in patients with normal IQ. Now, I mean, if you look as well, the p-values, they're not, but I'm just listing the findings. Now, The comorbid epilepsy was about 60% in patients with normal IQ, while it was about 76% in patients with mild cognitive impairment or intellectual disability. Now, they looked also at the frequent, like the epilepsy frequency at onset, at diagnosis. And they also looked at the resistance of anti-seizure medication. I'm gonna skip these and go to the other findings. So basically, they looked into the treatment because that's kind of the main point. And they saw that 20% had diagnosis communication, like a good communication of diagnosis in the normal IQ group, while 24% had basically a diagnosis communication in the mild intellectual disability group. Now, both patients, if you look at that, both groups had CBT. So 64% of the normal IQ group, while 60% in the intellectual disability group. And the combination of CBT and psychopharmacotherapy was higher in patients, like about 12%, but the number was not that different. Patients with mild intellectual disability. Now, upon follow-up, the cessation, like seizure frequency, like non-epileptic seizure or event cessation frequency was very comparable. So basically 48% in both groups had cessation, 24% had reduction, and in both groups. And we had 16%, so 4 patients in the normal IQ lost to follow-up and 5 in the mild intellectual disability lost to follow-up. Now, they also looked at the comorbid epilepsy and diagnostic delay. They were basically comparable also. All right, and we spoke about the cessation here, but that's basically with patients with comorbid epilepsy and the outcome. So with patients who had comorbid epilepsy, they had the patients who did not have comorbid epilepsy, they had about 91.7% cessation reduction in 6 patients, and persistent in 28.6% of the patients. Now, for the discussion part, so both groups exhibited a strikingly similar clinical background and demographics. And they were not really significant prolonged diagnostic delay in patients with mild ID or BIF compared to patients with normal IQ. And basically, this observation is basically compared to other studies, suggests that individuals with intellectual disabilities are more prone to misdiagnose with PNES as epileptic seizures. And detailed exploration by epileptologists revealed that emotion or situation triggers in 44% of individuals with mild ID and BIF and 40% of those with normal cognitive function. The authors attribute this difference to potential reporting bias in the previous literature, suggesting that individuals with mild ID and BIF might be less inclined to openly talk about their emotions. And patients had similar psychiatric comorbidities. Now, this study also supports the effectiveness of psychological interventions, particularly CBT, when adapted for individuals with mild intellectual disability and BIF, though it's predominantly used in normal IQ patients. I mean, technically, I was actually looking because I had a patient and I was looking, and that's how, with some mild cognitive disability, and I was looking on how to proceed, and that's why I came to this article. Now, psychological interventions, particularly CBT, can be useful in treatment of patients with functional non-epileptic functional seizures, not only for individuals with normal intelligence, but also for mild intellectual disability. And overall, 60% of individuals with and without mild intellectual disability were treated with CBT, and PNAS outcomes did not differ between the two groups. Now, again, some limitations of this study is that it is retrospective, monocentric, and conducted in a very specialized epilepsy center, which may have influenced the observed similarities between both groups. And it's small, and there was they excluded patients with more moderate and severe intellectual disability due to lack of clinical data. So that also like leaves these patients with we need to know more about whether CBT would be helpful or if it's doable in these patients. Now, in conclusion, again, individuals with mild intellectual disability experience a similar course of PNES as individuals without mild intellectual disabilities and do not require specific clinical management. And but obviously we have to kind of tailor the language used and communicate it to their diagnosis like the communication of the diagnosis and psychotherapy to the cognitive abilities. I'm going to stop here. I'm happy to answer questions. So basically, before that, I'm gonna announce the CME code, but I would like to give an announcement that we're finally, and I'm thankful for the efforts of Dr. Kubaisi and our department and psychiatry. We're going to have our functional multidisciplinary functional seizure clinic, which will start in 2 weeks, actually, approximately 2 weeks on October 4th. So I'll be working with Dr. Liu and Dr. Carrero, and we're ready to go. And let me share the CME codes.
Yaman, what's the youngest patient that you'll see in that clinic?
18.
Okay.
So patients will come on the same day, and they will see like psychiatry, Dr. Carrero, Dr. Liu from psychotherapy, and myself. And they will kind of come for like 3 hours or so and just stay there. Now it's every other week, but I'm hopeful it becomes every week. Yeah. Sorry, the CME code, I just realized I did not include it. I'm sorry about that. Share it. So this is the CME codes. All right, let me see. Well, thank you everyone for the congratulations and the chat box. I'm happy to have any comments, questions. All right. Well, thank you everyone for attending.
Thank you.
Thanks, Iman.
Of course, thank you.
Thank you, Dr. Mackey.
Thank you everyone. Have a great afternoon.
Thanks, Yaman.
You too.
Bye.
Bye.